Okay, so we have talked pretty extensively about a lot of different white blood cell disorders, and now we are going to add to that. So our previous lectures were mostly about myeloid disorders. We did talk about some we introduced some lymphoid disorders, but now we're going to talk in more depth about lymphoid and plasma cell neoplasms. So you may hear the term lymphoproliferative disorders when you're working in the lab, and this includes a variety or various forms of both leukemias and lymphomas that are of lymphoreticular origin. Now let's talk about the difference between leukemias versus lymphomas. So leukemias, which we've already talked about pretty extensively in our previous lectures, but they represent an overall proliferation or accumulation of hematopoietic cells in the circulating blood and or bone marrow. So in the case of a lymphocytic leukemia, we would see a proliferation of those lymphocytic precursors or lymphocytes in general would be proliferative. Um, or in the case of um, myelocytic leukemia, we would see those myeloid proliferations. Um, Lymphomas are a group of closely related disorders that are characterized by the overproliferation of one or more types of cells of the lymphoid system, such as lymphoreticular stem cells, lymphocytes, reticulum cells, and histiocytes. So these are going to happen not in the bone marrow per se, but more in the the lymphatic system or the lymphatic tissues and organs. All right, so we've kind of talked a little bit about chronic lymphocytic leukemia. It's one of our leukemias in which we're going to see a proliferation of mature B cells. So this is also considered a lymphoproliferative disorder. It is the most common form of leukemia in Western countries, primarily in adults. And of course, we're going to see this in an older or more mature demographic. This form of leukemia is rare before age 20 and uncommon before age 50. And remember, with chronic leukemias, we're going to see mature forms of the proliferative or proliferated cell population. So in this case, it would be B lymphocytes. Again, more prevalent in males than females, so 2 to 1, and it has the highest genetic predisposition of all hematologic neoplasms. We are going to have cells that are characterized with immunologic markers of CD5 positive, CD19 positive, and CD23 positive monoclonal B cells. CLL cells are also resistant to apoptosis. However, they do have a higher degree of fragility, so that's why we see smudge cells on the slide. Okay, so we didn't really discuss this in depth. Some of the staging of CLL, we're going to have stage 0, which is where bone marrow and blood lymphocytosis are occurring. So we have an elevated lymphocyte count. Stage 2, we may have lymphocytosis with some enlarged lymph nodes. Next, we're going to have lymphocytosis with an enlarged spleen or liver. In stage 3, we're going to start to see anemia because, again, remember that lymphoproliferation that's happening is crowding out healthy bone marrow and healthy bone marrow precursors for things like red blood cells. And then last but not least, we're going to have stage 4 lymphocytosis with thrombocytopenia. So that's, again, because healthy bone marrow or healthy precursors to red cells and platelets are being crowded out by proliferative lymphocytic precursors. So most of the people who are newly diagnosed with CLL are asymptomatic. And a lot of times we just discover it by chance. So they may come in for their yearly adult well checkup, and then we see that they have a super elevated lymphocyte percentage, or maybe they have smudge cells or abnormal or atypical lymphocytes that kind of have that soccer ball appearance. And we We of course report that if we don't see that the patient has had a history of either lymphocytosis or CLL. Typically, we'll send that to our pathologist just to verify, and oftentimes our pathologist will recommend following through with flow cytometry. So again, overcrowding of that bone marrow by leukemic cells can lead to anemia, thrombocytopenia, and neutropenia. And so what we're going to see is we're going to see a large number of lymphocytes um, and fewer of our other types of cells. So fewer neutrophils, fewer platelets, and fewer red cells. Um, we are also going to see a very elevated white blood cell count, although it's not typically as high as a patient with CML. And then lymphocytosis is going to appear in the bone in the peripheral blood. Up to 80 or 90% are going to be lymphocytes, whereas before lymphocytes usually are in a lesser percentage than the neutrophils. Another thing is so it's not uncommon to see those broken up cells every now and then on a normal diffs because sometimes cells can be damaged in the cell making process, but the presence of an excessive amount of these broken smudge cells is a characteristic of CLL because those CLL limbs are fragile and break easily. So we see them throughout the slide in large numbers. The amount of smudge cells is enough that it will drastically affect your differential. So of course we have to make that albumin slide. And we do that by taking 1 drop of albumin and 9 drops of human or of patient sample. We mix it together to make an albumin whole blood sample, and then we make a blood smear utilizing that. And that protein matrix from the albumin gives kind of a uh, durability um, to the cells that are present in the sample, and that helps maintain the cellular integrity. Um, so we always do our morphology off the original slide, and we always do our count from the albumin slide in the case where we see a large number of these smudge cells. So this top picture is a picture of a smudge cell. It used to be a lymphocyte and it was ruptured in the slide making process. This happens in vitro, not in vivo, but the intact lymphocytes at the bottom you see have that clumped chromatin and then those areas of clearing, which is called parachromatin. Those are going to be typical kind of characteristics of lymphocytes in patients with CLL. So again, because CLL is a chronic leukemia, also considered a lymphoproliferative disorder, it progresses more slowly in patients than patients with ALL. And so generally they have a pretty good prognosis. Previously, patients with CLL were only treated for palliative reasons, but numerous new treatments and options have become available for the treatment of CLL. Primarily allogenic hematopoietic stem cell transplantation could be a potential curative treatment available to patients with B-cell CLL. And then other newer treatments include chemoimmunotherapy, which was introduced in 2000. And basically, we use monoclonal antibodies in addition to chemotherapy, and that provides an increased survival time, but it's considered a treatment, not a cure. So this is a prolongation or an extension of life expectancy. However, it doesn't cure the patient from having CLL. Other treatment options might be supportive therapy. If the patient becomes too anemic, um, they may have to transfuse platelets or red blood cells in the case that they have thrombocytopenia or severe anemia. Although we don't really typically see severity, sometimes we do see it in moderate to mild forms, but typically we don't see CLL where a patient becomes so anemic or so thrombocytopenic that they need transfusions. Now, if this were to transform into an ALL, we might have a bigger problem on our hands. But for the most part, we just try to provide supportive therapy. And again, the only curative treatment available for patients is that allogenic hematopoietic stem cell transplantation. Although not all patients are, they don't all meet the criteria for that. And so that would really be up to the patient's care team to discuss those options and really look at the patient's history, et cetera, to make sure that they are a good candidate for that. Okay, I know we have mentioned hairy cell leukemia. Just to recap, though, hairy cell leukemia is pretty uncommon, and it is a chronic lymphoproliferative disorder of B cells. So similar to what we would see in um, CLL, but this is a little different. We usually see this affect patients over the age of 30, and it is more common in males than females. So hairy cell leukemia is named after the appearance of those fine hair-like cytoplasmic projections, and these are the characteristic cells or lymphocytes of this disease. So one of the interesting things is that hairy cell leukemia cells are resistant to the tartrate in the acid phosphatase stain or the TRAP stain. And this condition can also present with pancytopenia. Now, again, this is kind of a recap of some of these lymphoproliferative disorders. So make sure that you look at all of your PowerPoints and take notes on all of them, because each PowerPoint has a little bit more information, or a little bit, it's presented in a little bit different way. I try to simplify them after giving you a more thorough explanation. And so I'm just throwing this one in as kind of a reminder of what we talked about with HCL and CLL. Okay, so prolymphocytic leukemia, otherwise known as PLL, is not one that we really talked a lot about in depth, but it is this time a malignancy of T prolymphocytes. So we have those T lymphocytes. This is the pro phase of development, so immature phase of development, affecting blood, bone marrow, and the spleen. So you can see these are prolymphocytes. They have those nucleoli in the center there. They have kind of that dark colored cytoplasm. And go back to your developmental phases of your white blood cells and take a look at that, just so you can correlate. So what we're going to see is a large number of small lymphocytes with scant cytoplasm and immature features of prolymphocytes in the peripheral blood. So this is going to be circulating. These are going to be immature lymphocytes in their prolymphocytic phase. In order to be deemed or diagnosed as prolymphocytic leukemia, we're going to look at prolymphocytes and that number must exceed 55% of the lymphoid cells that are circulating in the peripheral blood. So this isn't in the bone marrow, this is peripheral blood. If we were to do a flow cytometric testing on this, we would find these to be of the T cell lymphocytic lineage or type, and not the B cell, whereas remember CLL is B lymphocytes and so is hairy cell leukemia. Okay, so here's just a little chart to kind of bring to light the immunohistological features of these selected B cell neoplasms. This, of course, does not include that prolymphocytic leukemia, because that would be a T cell neoplasm. And we have also talked about Burkitt's lymphoma that is associated with that Epstein-Barr virus. We're going to see a little bit more of that coming up. But first we have our CLL, or our chronic lymphocytic leukemia. Then we have our hairy cell leukemia and our Burkitt's lymphoma. So here are our cell markers. So we have CD5 positive for CLL, and then hairy cell leukemia and Burkitt's lymphoma are going to be negative. We are going to be positive for CD10 on Burkitt's lymphoma, and the other types of B cell lymphomas, B cell leukemias are going to be negative. And then we have a positive on CLL for CD23. The other hairy cell leukemia and Burkitt's lymphoma are going to be negative. And then both CLL and HCL are going to be positive for cell marker CD43 and negative in Burkitt's lymphoma. Okay, so we have talked about the lymphoproliferative disorders that fall under our leukemias, so CLL, HCL, and PLL. And now let's talk a little bit about lymphomas. So lymphomas are a group of closely related disorders that are characterized by an overproliferation of one or more types of cells in the lymphoid system. Malignant lymphoma usually expresses itself as a disorder of the lymph nodes and or lymph organs. So, like in all things hematology, we like to use classifications. Excuse me. And when we are classifying lymphomas, we divide it into two subtypes. We've got Hodgkin's and non-Hodgkin's types. These are going to be classified based on the type of cells that we see. So in Hodgkin's lymphoma, we characterize Hodgkin's lymphoma by the presence of a very specific hallmark cell called Reed-Sternberg cells. And then non-Hodgkin's lymphoma account for more than 2/3 of all lymphomas and more than 75% of the fatalities due to lymphoma. Rare forms of lymphoma include Burkitt's lymphoma and mycosis fungoides, and then Sézary syndrome. So pretty much we have Hodgkin's lymphoma and everything else falls under non-Hodgkin's lymphoma. Okay, so epidemiology, we see this across the board in all races and all ethnic groups. Um, it does not discriminate. And actually, I have my nephew, my sister's, um, well, her only son, actually had B-cell lymphoma when he was 10 years old. And he is now in remission and he's in his early 20s, but it was a really challenging time for my sister and her family. Lymphoma is the third most common form of cancer among children, following leukemias and brain tumors. So remember, lymphoma's third, ALL is first in terms of leukemias that children have, and then there are some brain tumors that are associated highly with pediatric patients. Now, Hodgkin's lymphoma is most commonly affected or affects children aged 15 years and older. So we see that in a group of pediatric patients and adults that are older. We don't typically see that in very young pediatric patients. Um, but when we break down Hodgkin's lymphoma, we have a couple of categories that fall under that Hodgkin's lymphoma. First, we have that nodular sclerosing or NS, and that's what affects about 70% of children. Then we have mixed cellularity, and that's the most common in children under 10. So there are some instances where we do see children under the age of 10 affected by lymphomas, specifically Hodgkin's lymphoma. And then lymphocyte predominance, which is more common in younger children. So um, I feel like I think the type of lymphoma that my nephew had was a non-Hodgkin's lymphoma. But let's move on and we'll get a better description in terms of lymphoma staging so that we can kind of see how physicians and caregivers and healthcare providers kind of know how advanced the disease state is. Okay, so with regard to lymphoma, we use something called Ann Arbor staging. With Ann Arbor staging, we have 4 stages. So we may have stage 1, which is going to be very localized into so one single lymph node or nodal region or a single organ is going to be affected. So you can see in this first picture, this patient has some cervical not lymph nodes that are affected, and that's it. When we get to stage 2, 2 or more lymph node regions on the same side of the diaphragm. So if you have cervical lymph nodes that are affected, and then you have some under your armpit, those are both above the diaphragm. Or if you have some that, maybe you have your spleen that's affected, that's maybe below the diaphragm, and then you have um, maybe some of your lymph nodes in your pelvic region are affected. That would still be um, two areas affected, but below the diaphragm. So those would still fall under stage 2. Now, in stage 3, we're going to see a little bit of a difference there. We're going to see 2 or more lymph node regions above or below and below the diaphragm. So you're going to have some above. They're going to be on opposite sides of the diaphragm, basically. And then with stage 4, which is the most severe or the more widespread disease state, we'll have multiple lymphatic or lymphoid organs with or without lymph node involvement. So it might be your liver, it might be your spleen, might be your bone marrow, it might be your lymph nodes, but it doesn't necessarily have to have lymph node involvement. All right, let's talk a little bit about Hodgkin's lymphoma. So what we're looking at over here in these two pictures, we have a close-up of what is called a Reed-Sternberg cell. It looks like two little eyeballs looking at you, and then we have a lower power on the bottom picture where right in the center you see one of those Reed-Sternberg. We cannot diagnose any lymphoma as Hodgkin's lymphoma if they do not have Reed-Sternberg cells. Reed-Sternberg cells are the defining features of Hodgkin's disease. Now, cytogenetic studies suggest that Reed-Sternberg cells arise from a single clone, so a common B cell precursor located in a germinal center. And if you think back to your immunology class, we're going to think about our thymus, our lymphoid tissues, and those germinal centers, and kind of just refresh your memory on that. Reed-Sternberg cells are usually less than 1% of the cells in a sample of Hodgkin's disease, and but despite their low percentage, it's really, really important to be able to identify those so that we can classify as a Hodgkin's lymphoma versus a non-Hodgkin's lymphoma. All right, so non-Hodgkin's lymphoma. So the most frequent type of non-Hodgkin's lymphoma is diffuse large B-cell lymphoma, or LBCL, which accounts for approximately 40% of new cases of lymphoma. More than half of the people with diffuse large B-cell lymphoma are older than 60. Now, this is I actually think this is the kind my nephew had, because I remember the doctors kind of being shocked that a 10-year-old was diagnosed with this large B-cell lymphoma or diffuse large B-cell lymphoma, because they kept saying to my sister, children just don't get this, children just don't get this. But he did. So even though the majority of patients who do have this diffuse large B-cell lymphoma are older than 60, it doesn't mean that everyone else is immune to it. So it's just more common in that demographic. Okay, so we've talked about Burkitt's lymphoma. First, we talked about Burkitt's lymphoma when we talked about our infectious mononucleosis, and then we talked about our Burkitt's lymphoma again and some of those proliferative disorders. But the WHO classification combines the acute lymphoblastic leukemia, ALL-L3, with Burkitt's lymphoma. There are 3 types of Burkitt's lymphoma that are recognized. So we have African endemic, sporadic, and immunodeficiency associated. So association of Epstein-Barr virus is seen in 100% of the African endemic Burkitt's lymphoma cases, 20 to 40% in the other 2 categories. And then approximately 1/3 of all of the pediatric lymphomas occurring outside of Africa are attributed to Burkitt's lymphoma. One of the characteristic cells that we see in Burkitt's lymphoma are these starry sky patterns. You can see these lymphocytes that have these vacuoles in them. So these are not monocytes, these are Burkitt's lymphoma cells. And they have these very prominent round bubbly looking vacuoles in their cytoplasm. Oh my, I hope nobody's offended. So Sézary syndrome and mycosis fungoides are non-Hodgkin lymphomas that are associated with T cell populations. So it does start with T cells in the skin, and that progressively infiltrate the lymph nodes and kind of form tumors. The presence of Sézary cells or those small lymphocytes have kind of a dark staining clumped nuclear chromatin pattern with a very distinctive folded groove-like chromatin pattern described as cerebriform, or sometimes we call them butt cells. So they've got a crack right down the middle of them. What we see in terms of their immunohistological markers is we see CD2 positive, CD3 positive, CD4 positive, and CD5. So those are kind of easy to remember, 2 through 5s. Okay, so moving on from our lymphoma category, let's talk about plasma cell neoplasms. So these technically are still lymphocyte of the lymphocytic lineage. And our two main culprits are multiple myeloma and Waldenstrom macroglobulinemia. Try saying that 5 times, my goodness. Okay, so with multiple myeloma, this is a malignant bone plasma cell neoplasm, and that's going to be associated with an abnormal immunoglobulin production. We're going to go into more detail about this in a minute. Plasma cell leukemia is an increased number of plasma cells in peripheral blood and should be considered a form of myeloma and not a separate entity. So when we start seeing proliferation of plasma cells or circulating plasma cells, we are going to investigate why. All right, so the epidemiology of multiple myeloma, we typically see about 5 cases out of 100,000 people. We have a higher incidence in men than women, and then a higher incidence in African Americans. So some of the environmental factors that contribute to multiple myeloma is radiation exposure, exposure to agricultural chemicals, manufacturing industries, again, that benzene, and then other chronic conditions like rheumatoid arthritis, allergies, and some infections. So all of these things can trigger a multiple myeloma. Some of the clinical signs and symptoms of multiple myeloma, historically they've been defined by the presence of end organ damage or specifically hypercalcemia, which just means elevated serum calcium levels, maybe renal failure, anemia, bone lesions. We use the, we kind of, I like to say, remember Babs the crab. And we'll talk a little bit more extensively on the next slide about that. Some symptoms that we see in patients with multiple myeloma are going to include bone pain in the back or the chest, weakness, fatigue, and the major symptoms result from acute infection, renal insufficiency, hypercalcemia, or amyloidosis. And we're going to talk about all of those things here in just a minute. I have a dear friend who is suffering with multiple myeloma right now. He's pretty stable for the most part, but it's been a long road, and I think right now he's just really trying to live his best quality life for as long as he has. But he was diagnosed about 3 years ago, so I haven't talked to him in the last couple of months, but last I knew he was doing okay, but still struggling a bit. Okay, so when considering a diagnosis of multiple myeloma, we're going to keep a few things in mind. Number one, we're going to remember Babs the crab, C-R-A-B. We have hypercalcemia. That's going to show a high level of serum calcium. And the reason for this is because at the same time, we are going to have some lytic bone breakdown. We're going to talk about that in just a second. We might see rouleau formations in our red blood cell morphologies, and that is due to excessive amounts of free light chains that are secreted by those malignant plasma cells. it causes the cells to be a little bit sticky, and then they form those stacked coin appearance formations. And then also, if you think about a whole bunch of proteins that become excessive circulating in the blood, of course, they may become toxic to the kidneys, because the kidneys are what really filter our blood. And what happens is they get kind of blocked up by all these excessive light chain proteins that are circulating. The worst part of it is all of these free light chains that are produced by these clonal plasma cells, they do not function. So they're completely useless, and they cause harm and not good. Next thing we're going to be looking at for our A is anemia. Well, we may have overcrowding of that bone marrow due to that malignant plasma cell proliferation. And then we are going to have bone lesions throughout the body. So we have an activating factor called osteoclast activating factor. Now, if you remember back to your anatomy and physiology class, we have bone breakdown and rebuild, just continuously breaking down and building up as needed. And so what we see is that osteoclast activating factor is stimulated by those malignant plasma cells, and that osteoclast activating factor is actually the trigger to stimulate the breakdown of bone and release calcium into the bloodstream. Now, normally what happens is when we have breakdown, calcium goes into the bloodstream, and then osteoblasts will take the calcium and rebuild our bones. Um, so that could happen during growth, that could happen during, even exercise when we're starting to get more bone density. But the thing of it is, plasma cells have something called interleukin 6 that inhibit the rebuild of bone because they inhibit the osteoblasts. So the new bone can't be formed. So what's happening is we have an over amount of breakdown due to that osteoclast activating factor that is stimulated by the malignant plasma cells. And then we have an inhibited rebuild due to that interleukin 6 that's present on the plasma cells. So it's kind of a double whammy. And that's why what we see in radiology tests of patients with multiple myeloma are lytic bone lesions. So they just start missing parts of their bone. But that also explains why we have elevated levels of calcium in our serum. Okay, so let's dig a little deeper into our laboratory results and some things that we might expect to see in a patient with multiple myeloma. First of all, in hematology, we're obviously going to see anemia. We are going to see a normal or low white blood cell count with relative lymphocytosis, because remember, those plasma cells are lymphocytic in nature. And because of that proliferation of the plasma cell population, it's going to crowd out other types of cells. We might see plasma cells and rouleau on peripheral blood smear, and we are going to have an elevated SED rate. Now remember, we talked a little bit about SED rates in the past, and what we're looking for in a SED rate is how fast red cells fall out of suspension or out of solution. So because we have all of these rouleau formations, they're heavier than normal red blood cells. So we're going to see them um, fall out of solution much faster than a normal, just plain old red blood cell that isn't joined by those clonal light chains. In chemistry, again, we're going to see that high serum calcium levels due to the bone breakdown. We are going to see high serum BUN and creatinine, and that is an indicator of renal failure, because remember, those light chain immunoglobulins that are circulating are toxic to our kidneys. If we were to do a protein electrophoresis test, we might see a quote unquote M spike in the gamma region. And there's an entire section about protein electrophoresis and chemistry. I will still give you a little bit of a brief overview, but you'll go into more depth once you get to Jenny and she introduces you to protein electrophoresis. There are a couple of miscellaneous things that we're going to see. So Bence-Jones proteins. So Bence-Jones proteins are a protein that are specific to multiple myeloma. And those Bence-Jones proteins are an indicator that without a doubt, we're looking at multiple myeloma. We've got multiple myeloma cells that express that CD38, so that's going to be through our flow cytometry testing. And then our bone lesions are going to be apparent on the radiology testing. We might also have a quantitative test of free light chains. And of course, that's a ref lab send out. Actually, we might do those now. I can't remember. There's one of the light chains I believe we still, or maybe it's free light chains that we do. So yeah, I think we do free light chains, but I'm gonna find out about that. It used to be a ref lab send out, and I think just in the last month or two we started doing it here. Okay, so just a very brief, non-specific overview of what we might see on a normal protein electrophoresis. So what we do is we run patient serum through electrophoresis gel, and of course, it gives us a pattern in terms of how far a protein will move down the gel. So this very first spike here in a normal patient will be albumin, and that's going to be really apparent. And then the next area we have is going to be our alpha 1 and alpha 2 region. So they're going to have alpha globulins here. And then we're going to get into our beta region, which is going to have our beta globulins here. And then we get into this gamma region. This gamma region is going to have this M spike, this monoclonal M spike in the presence of multiple myeloma. We may also see polyclonal spike, which is just going to be a little bit of a bigger hump. You could kind of see that on the right side. But normally we would have a very smooth kind of hill at the bottom in the gamma region. So this to the left is going to look is going to be more normal. And then over here we have kind of some crazy looking M spike. So the reason why it is called an M spike is because it's that monoclonal spike in the gamma region of the gel. Okay. That's nuts. If you look to the far left of the gel, you're going to see this dark red line here in the gamma globulin region, and that's where our M spike would be. That's what this graph is going to represent. Now, if you look at normal serum, which is all the way to the left, you have you don't really have a very specific, it kind of blends dark pink into light pink, and then you have that beta globulin, and then and then you have the alpha, and then both of them have a normal looking albumin. The spike that you see on the second is a patient serum, and you see very specific bands that correlate with that monoclonal protein or that M protein. We can do protein electrophoresis both on serum and also on urine. So the far right picture on that electrophoresis gel is a urine sample versus the serum sample that's on the other side. All right, so if we do a protein electrophoresis, we get that abnormal M spike in the gamma region, we are going to reflex to what's called an immunofixation electrophoresis. And that is where we're going to start looking for our IgG kappa light chains, our monoclonal gammopathy, and we're going to kind of do, I guess, a quantitative analysis of what type of immunoglobulins are there. So are we looking at IgG, IgA, IgM, kappa, lambda? What is it that we're looking for? And how many are we going to have? So first, we're still going to have that albumin. We're going to have alpha 1, alpha 2, beta, and then gamma. And these are going to correlate to, again, that M spike, and you can kind of see why it's an M spike. And then when we reflex to that immunofixation, we will then be able to quantitate which chains are, or which immunoglobulins are present and how many, basically. But you'll get a more thorough explanation again once you get to chemistry. It's kind of fascinating, and actually electrophoresis was one of my favorite areas of chemistry when I was a student. So, treatment for multiple myeloma is kind of tricky. It's not curable with conventional chemotherapy. There are some new treatments available, but of relapse is pretty high. There is the option for bone marrow transplant with high dose chemotherapy, and that does increase remission and survival. But unfortunately, bone marrow transplant and high dose chemotherapy are not available for a lot of multiple myeloma patients because they don't tolerate the procedures well. If you think back to some of our other conditions that require bone marrow transplant, typically younger people tolerate that much better than older people. And unfortunately, because multiple myeloma affects such an older demographic or population of people, the um, the prevalence of tolerating bone marrow transplant and high doses of chemotherapy are just not very good for elderly populations or patients with comorbidities. So infection is the number one cause of death in multiple myeloma patients, followed by renal insufficiency. And the reason for that is a patient who is producing a high number of worthless, dysfunctional immunoglobulins in the form of these light chains is not producing functional antibodies. And therefore, infection can kind of take over because even though we're producing all of these immunoglobulins, they don't work. And so these patients have a bunch of immunoglobulins that are just circulating, causing toxicity to the kidneys, their bones are breaking down. And on top of that, the immunoglobulins that they do have are totally dysfunctional. Most patients survive anywhere from 1 to 3 years after diagnosis. I think my friend was diagnosed about 5 years ago, I think 4 or 5 years ago. Went through a tough time, but actually he was down here at St. Luke's, or maybe it was KU, I can't remember. But they actually harvested his own stem cells and transplanted those to kind of replace his old bone marrow. So he didn't go through a bone marrow transplant, so to speak, but he did have some stem cell um, therapies that are kind of new. So I'm really hoping that that will be a success for him. He is on the older side. I think he's in his early 60s, maybe mid 60s now, but um, so far, I think he's doing much better than was expected. So hopefully, some of these new treatments and therapies are going to help prolong our life, the life of people who have multiple myeloma, and give them a better quality of life. Okay, so Waldenstrom macroglobulinemia, or WM. So this type of malignancy most commonly affects Caucasian males between the ages of 63 and 68. That seems very specific, but apparently that's kind of the window of opportunity. Um, what we're going to see is our plasmacytoid lymphs. Now, when you hear the term plasmacytoid, it means plasma-like lymphocytes, so plasma cell-like. Um, So these plasmacytoid lymphs infiltrate bone marrow and overproduce monoclonal IgM antibodies. So before we were having light chain monoclonal light chains, these are going to be in the IgM class. We might see bone marrow mast cells of WM overexpress that CD40 cell marker, and that is a potent inducer of B cell expansion. So now we've got these mast cells that are overexpressing CD40. It's stimulating even more. So what's going to happen is we're going to have an overexpansion of that B cell population. We're going to become hyperviscous, or sometimes they call it hyperviscosity syndrome. So kind of our blood is going to be sluggish just because of the elevated B cell populations that we have circulating. And we may even have hypervolemia, which remember is a term that we use for uh, larger total blood volume. We may see cryoglobulins, and those can be detected in the patient's serum. We do a cryoglobulin test here at St. Luke's where proteins that precipitate or gel when cooled to 0 degrees Celsius. And then we do a diagnosis using protein electrophoresis and immunofixation electrophoresis. So we're going to do protein electrophoresis, and then we're going to do a quantitative immunoglobulin test. So basically, we're going to see what kind of immunoglobulins are there. Better survival rate than multiple myeloma of about 5 to 10 years. It can look like multiple myeloma, but initially we won't see those bone lesions, and then we'll be able to make a definitive diagnosis using electrophoresis or IFE. So sometimes when we are doing protein electrophoresis for a suspected case of multiple myeloma, we may get what's called a monoclonal gammopathy of undetermined significance, or MGUS. And what we're going to see in this case is we're going to see a small M spike, but no other findings of multiple myeloma. It's going to be less prominent M spike than you would see with multiple myeloma. You're not going to have lytic cell lesions. You're not going to have elevated calcium. All of those things that we would normally see with multiple myeloma are going to be absent, and the only thing we're going to see is that a small M spike in that gamma region. Now, up to 11% of these patients will develop a multiple myeloma or CLL or a lymphoma within 5 years. So some type of lymphoproliferative disorder, it could be on the way for these patients. And I don't know that there is a lot of understanding about why, but we do know that there is a correlation between this monoclonal gammopathy of undetermined significance and a population of people who've demonstrated that on electrophoresis who later develop one of these lymphoproliferative disorders. And looky here. So I do have a couple more case studies for you. I'm not going to go through them with you in this lecture, but I do want you to try to work through them on your own. You can work through them as a group. You can utilize your notes. You can look through your PowerPoints. You can look through your textbook. But what I really like for you to do is think through each and every question and utilize all of the details of your case study to kind of determine the diagnosis, talk about the patient's prognosis, maybe what kind of testing we do, what kind of hallmark tendencies or cell types are we seeing that might point us in the right direction. How about our morphology of our white cells or our red cells, et cetera, et cetera. So utilize all of the pieces of information that we have learned about our lymphoproliferative disorders and kind of put them together. Now the answers are in this PowerPoint, and I believe the next slide has the answer to this case study, but I'd really like for you again to try your very best to work these through and come to the correct conclusion. So I only gave you 2 case studies, but I really would like for you to become familiar with the type of disorders that we are seeing, the nature of the proteins found, or maybe the things that are singular to that proliferative disorder. Just things that really help you know that this is specifically this particular disorder. And there are always going to be hallmarks. There are always going to be things that are singular to one disorder or another. For example, like when we look at Hodgkin's lymphoma, the only type of lymphoma that is associated with those Reed-Sternberg cells is Hodgkin's lymphoma. So if we see Reed-Sternberg cells, we're going to be like, oh, this has to be a lymphoma, a Hodgkin's lymphoma. So just kind of keep those things in mind as we go forward. And when we get to our case studies and then our practical exam for white blood cell, you'll have lots of practice under your belt. So good luck with studying. We will do a recap of these later on. This is kind of just like an overview, and I will try to post the recap tomorrow.